So this session will be regarding the aortic valve and the considerations in assessment of aortic insufficiency and aortic stenosis. We're going to begin the session by focusing on a few issues in hemodynamics. One of the calculation considerations is alignment of the Doppler beam with the flow of blood. To the left of the screen we see an optimal alignment with the flow of blood through the aortic valve in a deep transgastric view. This allows the Doppler beam to signal the velocities accurately. To the right of the screen we see a Doppler beam that's at almost a 28-degree angle of incidence with the flow of blood. Anything over a 15-degree angle of incidence will result in significant error in the sampling of the velocities and can lead to incorrect calculations of valve areas and cardiac outputs. Another important distinction to make in terms of physics is the difference between continuous wave Doppler and pulse wave Doppler. Continuous wave Doppler signal samples continuously, as the name implies, and allows the user to detect high velocities of flow. Thus, the area under the curve is filled with velocities at different points along the line of blood flow, and it is demonstrated as a solid signal curve. Whereas a pulse wave Doppler signals blood velocity only at a single point in space, and so it only traces a single velocity over time, so you get a hollow signal because it's only one set of data points. The way that continuous wave Doppler works is that it uses two crystals simultaneously in the transducer. One is constantly in receiving mode and one is constantly sending. This allows it to determine higher velocities of flow and should be used whenever velocities are greater than 1.2 meters per second. However, because it's always sending and receiving, we get a phenomenon referred to as range ambiguity, which means that you cannot tell exactly where along the line of blood flow the velocities are the highest. With regards to pulse wave Doppler, we use one crystal that alternates between sending and receiving the ultrasound beam. This time pulse allows for sampling of a discrete area called the sample volume and allows for excellent range resolution so that you know exactly what the velocity is at a given point. However, because the probe can only either be in sending or receiving mode, once you get to high velocities, you get a phenomenon called aliasing, which results in an inability to accurately measure these high velocity flows. So TEE is used to evaluate valve anatomy, valve function, and hemodynamics. So when we think about the aortic valve, we have to evaluate the entire apparatus, which includes the left ventricular outflow tract, the valve cusps, the sinus of Valsalva, and the proximal ascending aorta. The best or optimal TE views used to assess the aortic valve and ascending aorta are the mid-esophageal aortic valve short axis view, the mid-esophageal aortic valve long axis view, the deep transgastric long axis view, and the transgastric long axis view. We will talk about each of these views in succession. The mid-esophageal aortic valve short axis view is achieved in the mid-esophagus in an omniplane angle of 40 to 60 degrees with a focus on the right side of the heart. The probe is often in neutral, but sometimes can be antiflex to enhance image acquisition. It's important to note the number of leaflets should be 3 on the aortic valve, and you should be able to see 3 equal and symmetric leaflets in a normal aortic valve. It's important to evaluate the mobility of the leaflets. Look for things like commissural fusion or calcification. You can size the valve of the aortic valve by using planimetry as a function. And you can assess with color flow Doppler for aortic regurgitation in this view. Here we can see the labeling of the 3 aortic valve cusps. The left coronary cusp is between 1 and 3 or 4 o'clock on the clock if the aortic valve was a clock face. The right coronary cusp is at about 4 to 8 o'clock on the clock face, and the non-coronary cusp is between about 8 and 12 o'clock on the clock face. The non-coronary cusp points towards the interatrial septum, the left coronary cusp points towards the left atrium, and the right coronary cusp points towards the right ventricle. Here we see another image of an aortic valve. And what we want you to focus on here is the fact that the leaflets don't look symmetrical. This is probably because we need to adjust our omniplane angle. However, we can see that the valve opens easily and fully, and that there does not appear to be any limitation in the ability of the valve to open at the commissures. So this is likely a normal structured aortic valve. You can either decrease the depth or zoom in when assessing the aortic valve and trying to do functions like planimetry to assess the aortic valve area. And that's what has been done in this image. You can see even closer, and there may note a little bit of calcium at the tips of the leaflets and along the commissures. Now we will talk about how to assess the aortic valve by planimetry. The first thing to do is obtain a mid-esophageal aortic valve short axis view, optimize the image by reducing gain, change the depth so that the aortic valve is the focus of the screen, and then when the image is frozen, trace the orifice with a tracing caliper. One caveat is this is not very accurate when the leaflets are heavily calcified, or if there's shadowing or reverberation artifact from other sources as well. There can also be a significant amount of inter-observer variability in terms of calculating the aortic valve area by planimetry, particularly when the valve becomes smaller. To the top left of the screen, you see a normal aortic valve with a large opening in systole and a valve area of 4.3 centimeters squared. To the right bottom, you see a very heavily calcified valve that's almost boomerang shaped in the orifice in systole, and the valve area planimeters out at 0.86, which is severe aortic stenosis. The mid-esophageal aortic valve long axis view is a very useful valve for the place to assess the aortic valve. The omniplane angle is positioned between 120 and 140 degrees in most cases, with the probe positioned in neutral. Sometimes if you're focusing on the left ventricle, you may have to retroflex the probe a bit, but typically the neutral position is optimal for assessment of the aortic valve. Here you can take measurements of the left ventricular outflow tract and aortic root to assess for dilatation, and use measurements of the left ventricular outflow tract in calculations of aortic valve area and cardiac output. You can also place a color flow Doppler across the aortic valve to assess for aortic regurgitation. When looking at the ascending aorta, which is seen at the far right of the screen, you may have to withdraw the probe a bit to see more of the ascending aorta in the image. It's important to examine for aneurysmal dilatation, abnormalities of the aortic root, atheroma, dissection flaps, or partial obstructions of the left ventricular outflow tract from things like hypertrophic obstructive cardiomyopathy or systolic anterior motion of the aortic valve. The stylized simulator images at the top demonstrate an idealized view of the mid-esophageal aortic valve long axis, showing very clearly the left atrium, the left ventricle, the mitral valve, and the aortic valve. The image on the bottom right shows a more real-life picture. Notice in this case, the ventricle is less bullet-shaped and maybe a little bit more dilated and globular. That may be the result of foreshortening of the chamber and require retroflexion of the probe, or it may just be that the patient's heart is a little bit dilated in this image. Notice also that it's often hard to see that aortic root, as we discussed in the last set of slides, and so that you may have to withdraw the probe a bit to see that proximal aortic root. To the bottom left of the screen, we see a schematic that is adapted after standard echocardiographic images and shows all the structures in a line drawing. For obtaining the deep transgastric views, the omniplane angle should be at 0 degrees for the normal deep transgastric view and up to 120 degrees for the transgastric long axis view. The probe is typically antiflexed to achieve these views once the probe is placed in the stomach and a transgastric mid-papillary view is obtained. The probe can be advanced slightly deeper, and then the transgastric mid-papillary view and antiflexed to achieve the deep transgastric view, or rotated to 90 to 120 degrees from the mid-papillary view in order to achieve the transgastric long axis view. These views are both particularly important for detecting and grading aortic regurgitation by color flow and measuring transvalvular and subvalvular gradients for aortic stenosis. We will see on the next few slides how we can measure the velocity time integral of transaortic flow in order to calculate aortic valve area and cardiac output. First, though, let's take a look at the left side of the screen where we see the position of the probe in the stomach pointing up at the apex of the heart. That will help us compare to the right side of the screen where in the echocardiographic image the echo probe is positioned at the top of the screen. Hence the heart is flipped upside down in this image and the apex is at the top at the 12 o'clock position. The aortic valve is at the bottom at the 6 o'clock position, with the ascending aorta and aortic root coming out of it. In this slide, we can clearly see the alignment of the Doppler beam is very good in this deep transgastric view across the aortic valve. This is the perfect place to get gradients and to calculate velocity time integrals for the left ventricular outflow tract and aortic valve. The transgastric long axis view is obtained by taking a mid-papillary view and then rotating the probe out to about 100 or 120 degrees. The Doppler beam can usually be aligned pretty easily across the aortic valve, as it is in this picture, although not always. In terms of evaluating aortic insufficiency, it's important to look at the valve structure visually in 2D echocardiography, and then grade the severity of aortic regurgitation by a variety of different modalities, including color flow, jet width, and other indicators, which we will discuss shortly. It's important to look for other valvular or subvalvular structural abnormalities, assess for review of reversal of flow in the descending thoracic aorta, which can be an important indicator of severe aortic insufficiency. Also, because aortic insufficiency is classic volume overload, the left ventricle tends to become dilated in long-standing aortic insufficiency. As the left ventricle becomes dilated, left ventricular function may also become impaired. So assessment of left ventricular function plays into the assessment of aortic insufficiency. This is a classic flow volume loop of aortic regurgitation. Here we see increased end diastolic volume, which demonstrates increased preload. And we also see increased in end diastolic radius pressure and afterload. This has to do with the law of Laplace, where wall tension equals pressure times the radius of the cylinder. As the radius increases, therefore, the wall tension increases as well. It's important to note that while rheumatic disease classically causes aortic stenosis, that malcoaptation of those heavily calcified leaflets can also lead to aortic regurgitation. And this is a common etiology for aortic insufficiency. In this picture, we see a mid-esophageal aortic valve short axis view with color flow Doppler placed across the valve. Notice that the Nyquist limit is 55 to the left of the screen. That's an adequate Nyquist limit. Whenever assessing the aortic valve, it should be between 40 and 65. So that is something we observe before we even assess the severity of aortic regurgitation, since if that Nyquist limit is low, you may artificially be seeing aliasing that suggests more severe aortic insufficiency. In this case, that's a totally normal Nyquist limit, and we see in the short axis that there is a small amount of color flow leaking back through the valve and diastole, suggesting trace aortic insufficiency. Here we see the two-dimensional view to the left demonstrates the mid-esophageal aortic valve short axis, where it looks like the valve opens and closes quite normally. However, when we put color flow mapping on, we can see that there's a plane of malcoaptation all along the interface of the left coronary cusp with the right and non-coronary cusps that results in significant aortic insufficiency. So color flow is an important modality, even if the valve visually looks like it coaps well. Here's an example of assessment of color flow in the mid-esophageal aortic valve long axis. One of the things that we traditionally have looked at is the length of the aortic insufficiency jet extension into the left ventricle, but that's been shown more recently to correlate poorly overall with severity of aortic insufficiency, mostly because of the effects of loading conditions and left ventricular compliance on this measure. However, it still may be used in concert with other modalities to help predict severity of aortic insufficiency. As a rule of thumb, if the aortic insufficiency extends past the papillary muscles, it's at least moderate to severe, and if it touches the back wall of the ventricle, it is severe. In the deep transgastric view, this length of aortic jet extension can also be evaluated, and in this case you can see that it extends significant distance into the left ventricle. Another way that we assess aortic insufficiency is comparing the width of the aortic insufficiency jet to the width of the left ventricular outflow tract. This can be done in two-dimensional or in M-mode views, which is what we illustrate here on the slide. At the top, we see the left ventricular outflow tract characterized by M-mode echocardiography. So there's a box of bright red that demonstrates systolic ejection. And then in diastole, we see a narrow band of turbulent color flow that takes up a third or less of the dark blood area in the left ventricular outflow tract, suggesting that it's mild aortic insufficiency. Whereas at the bottom, we can contrast that diastolic flow, which takes up nearly the entire left ventricular outflow tract band, suggesting that there's severe aortic insufficiency. Vena contracta is another important modality in assessing aortic insufficiency. To measure a vena contracta, you measure the narrowest portion of the regurgitant jet as it passes through the plane of the valve. It is most often measured in the mid-esophageal aortic valve long axis. You can also measure it in the mid-esophageal aortic valve short axis. However, as a rule of thumb, 3 millimeters or less is trivial, 3 to 6 is somewhere between mild and moderate, and severe is greater than 6 millimeters for a vena contracta. Aortic stenosis can manifest with a variety of hemodynamically significant symptoms, such as congestive heart failure, syncope, and angina, and that's a classic triad of symptoms. It results in an increase in afterload with increased wall stress that leads to ventricular hypertrophy, and over time a decrease in compliance leads to diastolic dysfunction and large dependence on adequate preload for filling. In terms of quantifying the severity of aortic stenosis, we can planimeter the valve, as discussed earlier. We can measure peak velocities or peak or mean gradients using Doppler techniques. Or, most importantly, we can calculate the aortic valve area by continuity equation. We can also use M-mode or motion mode and LVOT to aortic valve VTI ratios, but we'll spend less time focusing on those. Here's a classic pressure volume loop for aortic stenosis. We see that for any given volume, the pressure generated in the left ventricle is extremely high, and that the end diastolic volume is significantly shifted from baseline. Here we see an example of the mid-esophageal aortic valve short axis, where it looks as though the left corner cusp and right corner cusp may be partially fused, and the non-corner cusp is heavily calcified and poorly mobile. This is likely at least moderate or probably severe aortic stenosis. We can see as we move in closer here that there is a slight separation of the left and right coronary cusps, but not substantial, and that likely confirms our initial diagnosis of severe aortic stenosis. In this case, we also see a mid-papillary transgastric view that demonstrates significant left ventricular thickening and hypertrophy, and a small end diastolic a small end systolic volume, suggesting some underfilling. In this example, we see to the left a heavily calcified, possibly rheumatic valve with poor separation of the left and right coronary cusps, but a relatively mobile non-coronary cusp. We see a trace degree of aortic insufficiency on the right in diastole. So this is probably somebody with moderate aortic stenosis and trace aortic insufficiency. We would have to do further testing on both, however, to confirm. In this case, in the mid-esophageal aortic valve long axis, we see a poorly mobile leaflet at the bottom of the screen and a relatively mobile leaflet at the top of the screen. We would have to undertake a variety of other views, but in close-up we see that we can confirm that the bottom leaflet is simply not moving well at all. Here we see a left and non-coronary cusp that may in fact be fused or congenitally bicuspid, and a slightly larger than normal or misshapen non-coronary cusp. This would require further assessment, especially color flow, since it's likely that with that degree of calcification that there's also concomitant aortic insufficiency. Here in the mid-esophageal aortic valve long axis view, a color flow image shows no leakage back in the left ventricle in diastole, suggesting no aortic insufficiency in this case. In terms of quantitative assessment of the aortic valve, we can use the Bernoulli equation to convert velocities into peak gradients, and the continuity equation to help us calculate aortic valve areas, either using velocity time integrals, peak gradients, or peak velocities. These methods require the use of the deep transgastric or transgastric long axis views to align the Doppler beam as previously discussed. Here's an example of a hollow wave, which hopefully from our previous discussion you recognize as a pulse wave Doppler. It's been gotten in the deep transgastric view, which you can see at the top of the screen in the small echo sector. And it's a pulse wave image through the left ventricular outflow tract. We see a velocity of about a meter, 1.1 meters per second. So that's within the range that's reasonable to use a pulse wave Doppler on, which is our standard for the left ventricular outflow tract. We would freeze this and trace a velocity time integral. One concept to review at this point is the concept that as blood flows through a more narrow orifice, either a stenotic portion or a narrower portion of the vasculature, or through a valve, it has to compensate by increasing its velocity of blood flow in order to continue to move forward at the same rate. So in this case, in the deep transgastric view, we're going to use the Bernoulli equation to calculate a peak gradient from a peak velocity. We have a peak velocity of 3.2 meters per second, and we apply the Bernoulli equation, modified Bernoulli equation, and use 4 times that peak velocity squared to get a gradient of 40 millimeters of mercury. We can use mean velocities as well to calculate mean gradients. 4 times the mean velocity squared with this modified Bernoulli equation would result in a mean gradient. And the mean gradient we like because it correlates well with invasively measured pressures. One caveat is that gradients are flow dependent and therefore should not be considered as a primary method of assessing aortic stenosis. Here's another example of a continuous wave through the transgastric long axis view, which we can see at about 110 degrees at the top of the screen. The image that we see here has been traced to give us a mean pressure gradient and a velocity time integral, as well as a peak gradient. And the peak gradient is 10 millimeters of mercury. So, to summarize and demonstrate the continuity equation, we understand already that the cursor should be parallel to the direction of blood flow, either the deep transgastric or the transgastric long axis. We need to measure the left ventricular outflow tract and the mid-esophageal aortic valve long axis view, and we need to trace those aortic valve Doppler signals that we obtain in those transgastric views. We need clear envelopes, and we need to make careful measurements of that left ventricular outflow tract diameter in order for the calculations to be accurate. The basic premise of the continuity equation is that what goes in must come out. So if something passes through the left ventricular outflow tract in terms of a volume of blood, it also has to code through the aortic valve. So a stroke volume is a cross-sectional area times a velocity time integral. So to get a cross-sectional area, you do pi times the radius squared of that region, and then you measure the velocity time integral. Based on continuity equation, we understand that the stroke volume through the left ventricular outflow tract has to equal the stroke volume through the aortic valve, and thus to get aortic valve area, we can divide both sides by the velocity time integral through the aortic valve. This slide is an important slide and demonstrates the fact that the left ventricular outflow tract needs to be measured about a centimeter below the aortic valve. The aortic valve is demarcated by 2 yellow X's here. Left ventricular outflow tract is demarcated by the crosses instead. It's important to measure that carefully because it's a value that's squared, pi times the radius squared, remember. So we take this diameter, cut it in half to make a radius, and then we square it. That can result in the highest source of error in your calculation, so it's important to measure this multiple times and be consistent. Here is a double envelope technique where we use continuous wave and can also see the flow through the left ventricular outflow tract as a lower velocity wave in it. You can potentially either trace these waves to get velocity time integrals or use peak velocities from both of these waves. With continuity, you can approximate peak velocities to velocity time integrals, although velocity time integrals are technically more accurate sorts of findings. here we have an aortic valve area that was calculated at 0.52 with this double envelope technique using peak velocities. Notice that they've simply put the samples at the peak of the left ventricular outflow tract gradient, which is that lower gradient, and at the peak of the aortic valve gradient, and use that to approximate velocity time intervals. This concludes our discussion of aortic stenosis and aortic regurgitation. It's important to remember that a thorough examination with color flow, pulse wave, and two-dimensional Doppler is critical to the assessment of this valve. Thank you.